Okay. Well, welcome everyone. We are back. We had some technical difficulties, so I apologize. We're getting a little bit of a late start. We have an interesting topic this afternoon. We are looking at myths and truths of COVID-19. Our guests today are Dr. Scrase, our Secretary of the Human Services Department, and we have Dr. Richard Larson. He's the Vice Chancellor of the Health Science Center at UNM Hospital. They'll give us some quick presentations on what's happening with modeling in New Mexico, what we think we might be able to expect with the future of the virus here in New Mexico, and also get some updates on what is happening in the world of vaccine research. And then we've got lots and lots of questions, and so we'll try to get to as many of those as possible. So as we go, let's invite Dr. Larson to offer his presentation.
Thank you. Thank you, Steve, and it's great to be here with you and Secretary Scrase. I just have a brief presentation to give an overview and reminder on several of the concepts related to testing and vaccines. And then I think Dr. Scrase is going to speak more specifically to New Mexico, and then we'll tag team on the large number of Q&A that we have today. So if you could call up my presentation, please, Daniel. Okay. I assume Daniel's going to display it. I can go ahead and start talking without the slides.
Let's see what we can do without the slides.
Okay, so what I'm going to talk about is just tell you a few things about testing, tracing, therapeutics, and vaccines. So one of the things about testing is that New Mexico has been one of the foremost states in terms of leading the country in the percent of the population that's been tested and how effectively we have been testing. And I think some of the questions that came up involve types of testing and so forth. There's really two types of testing. One is high volume, and that's where we can collect a lot of samples, like at a drive-through or other places on a daily basis. It goes to a central lab, like the state lab or Tricor reference laboratories, and there's machines there that can do thousands of tests a day. And then there's a lot of what's read in the press, which are called point-of-care testing instruments. And these are small little boxes that would go sometimes in a hospital, but also in a doctor's office, where you can do an individual test. But that individual test usually takes anywhere from 15 to 45 minutes. And so you can't do very many a day that way, but the patient who's being tested gets their result back within an hour. So that's the testing piece. I know monoclonal antibody testing has come up. That is not a test of whether you have infection, but at some point, have you been exposed to the infection? And so I know there's some questions about that, and we'll answer those questions later on. But effectively, that tells you if you've been exposed. And the tests right now do not tell you if you're immune. They only tell you if you're exposed, and we can talk a little bit more about that in detail. After you have testing, you really need to have tracing, which means once you identify somebody who's infected, you've got to find out who they potentially have exposed in the last few days, and you have to have a system to go back and find those people and get all of those individuals tested as well. Now, on the vaccine front, I think things with the vaccine are moving more rapidly than ever. There's a minimum of 7 private companies or the federal government through NIH that are testing different vaccines right now. And one of the big issues people always ask is, why does it take so long? Well, because you have to produce the vaccine in small amounts, and then you have to test it in humans, and testing it in humans takes several months at least. And then once you show it's effective, you've got to then produce hundreds of millions of doses. And so to be able to do that potentially by the end of this year is an unbelievable success for the United States in terms of being able to potentially do that many vaccine trials and potentially come up with one and produce it in time for the next flu season. And if that happens, that'll be the most rapid we've ever been able to do that. And then finally, there's therapeutics. And I think there's been some success. I think people have heard with this new drug called Redevere, which is really more for severe cases of COVID. The trials with hydroxychloroquine and zithromycin, I know they are ongoing, but there's a lot of mixed reviews in the scientific literature, and I know there's some questions about that. And then there's convalescent plasma, and we can talk about that during the Q&A as well. The final thing I'd like to talk about is a unique genetic mapping study that we're doing at the University of New Mexico, and it's really unique to the United States. And that is in collaboration with the Department of Health State Lab, we're getting Antricor, we're getting part of all the positive samples in New Mexico and sequencing each virus sample genetically. What this will allow us to do is to figure out where the virus came from in New Mexico. So for instance, we already know that there doesn't seem to be cases that came into New Mexico from China. We do know that a number came from New York. So and Europe. And so over time, we'll be able to really map the pattern of how the infection came in and who it came from and where it went to. And so I think that'll be a pretty exciting set of findings once all that information comes in as well. So hopefully that wasn't suffer too much because you didn't get to see pretty slides as I went along. But hopefully that's a little bit of an introduction that can set us up for the Q&A that is coming and Dr. Scrase's presentation, which is after mine. So speaker, I'll just leave it to you now.
Thank you. I think the technical issues are going to prevent us from having presentations of slides. Dr. Scrase, I don't know if you'd like to visit with us for a few minutes in a slide-free format, if you'd like to.
Sure.
Maybe just introduce the topic, and then we can go to some of the questions that we're getting.
Yeah, I'm happy to do that. Just to say that it's a real pleasure to be here with the speaker, Egoff, and Dr. Larson. Dr. Larson and I worked together very closely at the university before I came to the States, so it's great to be on a panel with him again. I'm just going to talk briefly about reopening the economy and how we're doing that and what the process is. And the first step is that the federal government set out some criteria that they thought states should adhere to for reopening. Then every state promptly went about coming up with their own criteria, although there's an awful lot of overlap. And it turns out now that our overlap is pretty close to other states. There's a website that's called COVIDexitstrategy.org that sort of has a map of the United States. And as you probably know, all 50 states are reopening. That map today shows that only 2 states are really ready to do that, New Mexico and New York. And so I think we are in a good place. We've used a lot of data, none of which you're going to be able to see, but a lot of data to make those decisions. The governor is very intent on using science, using data to make those decisions. And so we have 4 things that must be in place as we start reopening. The first is the spread rate of COVID-19, and some very, very clever people in 2003 found a way to actually use math to calculate the rate of spread by just inputting the number of cases each day in the SARS, the original SARS pandemic. And and the number tells you for every 1 person with COVID, how many people will be infected. So ideally, you want your number to be below 1. When it's below 1, the epidemic goes away. We were running about 1.3 in early April. The virus itself, with no social distancing measures, every person who gets it infects about 3 people. So 1.3 is much better. We set our target at 1.15 spread rate, and we're down to 1.09 today. So we're doing well there. We set a target for doing 5,000 tests today, and Dr. Larson mentioned we're one of the highest per capita testing states. We're at 4931, so we're just barely below, but the national standard is really 3,300 for New Mexico, so we're doing well. Dr. Larson also mentioned contact tracing and isolation of both the initial case and their contacts, and we have some metrics on that around time that we're doing well. And so, and lastly, there's the capacity of the healthcare system. Remember, when we first started this, most of this social distancing was to protect New Mexico from having our delivery system overrun, like we all saw on television in China, Italy, New York City, and other places. And so we keep close track of the ICU capacity of our main hospitals, 7 of our main hospitals in the state, who have about 90+% of ICU beds. And actually today they're at 292. Our capacity is 230, but the team that came together across the whole state to set this up actually found a way to double the number of ICU beds by setting up other rooms as ICU. So even though we're 62 over our capacity, we have a total expansion capacity above baseline of 230. So we're doing well. And then we also monitor PPE in hospitals, personal protective equipment, and they're all set. That was a challenge at the beginning, but has gotten better. We are past our peak, we believe, in New Mexico. We think that peak happened on May 1st, although it's tricky because the cases went up sharply, and now the peak is kind of coming down much more slowly. So we're watching that closely, but every region in the state is doing better over the past 4 weeks, except for the Southwest, where cases are going up, but that's very reassuring as well. So the last thing we monitor is motion data, cell phone motion data, to see how much folks are moving around the state. And well, we've monitored a lot of things, but this is the one I'm going to talk about today. And we did see a significant drop off, like a 50 to 60% drop off in mobility during the stay-at-home order, with a low point on April 14th, I think, 13th, which was Easter. That's going back up again. Our motion data is going up again slowly, but we're still about 20%, 25% lower than when we started, which we hope means less spread of the disease. And I think with that, just one other thing that you all might be interested in, we've seen a 20% or more increase in applications for programs like Medicaid, SNAP, the food program, and income support, energy bill support over the past month. It peaked in mid-April, and now those applications are coming down. But we do have a lot more people in those programs than we did before as a result of the changes to the economy that the coronavirus brought. And so with that, I'll just stop, and we can handle questions however you like.
Great. As we go to questions, I would like to ask for either of you to address kind of this will be our first Mythbusters moment of our session here. And, there is a lot on social media and a lot of protests where people are saying wearing a mask is pointless. They say Dr. Fauci and the Surgeon General back in April said no one needs to wear masks. Would you please, doctors, once and for all, explain to the folks in New Mexico and the folks watching why we are now being requested and instructed to wear face coverings when we're out in public, why it works, and what we're doing when we wear a mask?
Yeah, I can start, and I have a wonderful slide that you can't see, but we did make the presentations available, and I'm assuming Daniel will send them out. There's a ton of confusion about masks because there's data about PPE type masks, which really do protect healthcare workers from getting infections. And then there's some data, not as good, certainly, about cloth masks and multi-layer cloth masks for the public. And so and the one thing that this is really a common myth. I think the myth behind the question is that science never changes. And if somebody says something in April, it's going to be true in May. And what we're seeing with the COVID epidemic is really there's a lot more science that's coming out, a lot more papers published about COVID. Not as good of peer review though, or evaluation of those papers, which makes it tricky. But they're, Asian countries have been wearing masks, not even during pandemics, for quite some time, and there is some evidence that a multi-layer cloth mask, if 80% of the population wore a cloth mask that was 50% effective, we could reduce the death rate in New Mexico by 17 to 41%, which I think is about 1,700 deaths saved. Healthcare PPE masks protect healthcare workers from getting COVID. Face coverings and masks that people wear in public tend to prevent or reduce the chances of you infecting someone else. So very different purposes for both, very different uses, but a ton of confusion. I just read a paper yesterday where someone cited all the potential side effects of the kind of PPE N95 respirators that people in intensive care units wear, why that would be bad for the public to wear those. And of course, nobody's suggesting that the public wear them. So there's some value, and the cloth coverings, face coverings mainly protect other people from you.
Thank you.
Yeah, I would just amplify that. I think people, when you wear a cloth mask in public, you're wearing it so that if you don't know you're infected, you won't infect others. And so if everybody wears them in public, there's less chance that somebody inadvertently affects somebody else. The type of mask you wear in a hospital, you're wearing as a doctor or other healthcare provider so that you don't get infected when you're taking care of a patient. So very different purposes, but both very important.
Yeah, and it's something that no one necessarily likes, but it's important to keep in mind that we do it for others, so we don't unwittingly infect, and hopefully it'll become more normal and accepted as we go through this important process. We have a question from Susan Dunlap at the New Mexico Political Report. She asks, what can you tell us about blood clotting and the virus? Can you talk about how blood clotting is leading to things like strokes and other issues? And have we seen any of that here in New Mexico?
There's a lot out about sort of the tendency of people with COVID to develop blood clots, particularly in their legs. A lot of folks nationally are using routine anticoagulation or blood thinners for people to prevent complications. There is a slight increased incidence of stroke, and that could be in people with heart defects who develop clots that then break loose and go to their brain. But clotting is a known side effect, and particularly in intensive care units, I know there's trials going on right now to test the benefit of routinely putting everyone on a blood thinner when they first come in.
And just to amplify on that, the cause of the blood clots aren't known. And one of the things that I think we're going to have to figure out nationally, and there are clinical trials that are trying to determine this, is a lot of patients with COVID infection also have other diseases, which are called comorbidities, and how much those other diseases influence whether they get blood clots or not is also a factor. And so all of that, I think we just don't have enough information yet to know the exact risks and the exact causes.
Thank you. Lucinda Laro is asking, does having the virus and recovering from it provide immunity to reinfection? What's the latest on that?
I'll let Dr. Larson start on this one. It's an interesting topic.
So, when you exposed to the disease, you develop an antibody, and that's true when you get any sort of virus infection. And the issue is, for any viral infection, you develop an antibody, but for some viral infections, it's not protective, and while others, it is. So for instance, people with HIV develop tons of antibodies, but none of it protects them from, getting HIV. And likewise, there's plenty of viruses. If you get chickenpox, you develop an antibody that protects you for most of your life, if not all your life. And so what's not known is if and how many of the people that develop the antibody because they've had the disease have an immunity because they've developed enough antibody or the right type of antibody. It's pretty clear that some people have some immunity, but it's also probably possible or probable that some people don't have much immunity. And we just don't know enough, and we don't have the testing to accurately predict exactly who has immunity and who doesn't have immunity, although we can tell who's been exposed to the disease because they have an antibody. And right now they're developing the test that detects the antibody. There's several groups nationally that are doing the next scientific steps to make that antibody test a test that will predict immunity. It's just not been developed yet, but it will be coming.
Mm-hmm. Barbara Red asks, how concerned should we be about the virus on surfaces? For example, if you have a package delivered to your house or if you have takeout delivered to your house, what can we tell folks about how risky it is to open up a box from the Postal Service or UPS?
Yeah, there was a great article in the New England Journal of Medicine about a month ago about surfaces and COVID survival on surfaces. They looked at copper and cardboard and a bunch of different materials, plastic. Turns out that the virus doesn't like porous surfaces. So cardboard, for example, it degrades pretty quickly, but plastic, it can last a fairly long time. So I think, keeping everything clean is not a bad idea. The CDC recently changed their website to emphasize the fact that surfaces weren't the main way that you get COVID. You get COVID from being around other people who've got it. That's how you get it. But then they had to come back and say, well, but we didn't mean to downplay it. It still can be translated. So I think it's not a bad idea to wipe down things that come in the house and things like that, keeping surfaces clean, particularly if you have porcelain or plastic surfaces anywhere in the house, keeping them clean. But I think that's another area where we just don't know enough to be certain about what to do. Last thing is some people wear gloves, and gloves actually may be less helpful than not gloves in that they tend to reduce your dependency on washing your hands. And plus, if you don't know how to take gloves off, if you haven't been properly trained in taking plastic gloves off and you have COVID on your gloves, you can actually immediately shoot it into your respiratory system in your eyes. So I think a modicum of concern about objects coming into the home that is not bad, but I mean, it's probably a good thing, but we don't need to overdo it. I don't put all my groceries in the dishwasher before I put them in the refrigerator.
At home, my wife is always wanting us for years to take our shoes off when we get in the house, and she has used this COVID crisis to finally convince us of the propriety of taking our shoes off. So she's finally got us to do it. So one modicum of being safe, of not tracking it in the house, maybe. How is this? So there's a lot on social media, a lot on the internet, where people are trying to make the claim that COVID-19 is no worse than a seasonal flu. And we see, people say that the number of deaths are the same as a bad flu season. There's a lot of, I think, selective use of data. What can you say to people that are watching who want to be able to refute the notion that COVID-19 is no different than the seasonal flu in terms of deaths and impact on our healthcare system?
Well, the case fatality rate of influenza, which is where you take the number of people who get the disease on the bottom, and the number of people who die on the top is 0.14%. And the case fatality rate for COVID in New Mexico is, I don't have the exact number on the top of my head, but it's running higher than 2%, 2 to 3%. So, to me, that's 20 times worse. I think so at least what we know so far. Now, what we don't know is we don't have the same kind of testing, and we don't know about the antibody testing Dr. Larson referred to. We don't know how many other people are out there in the community that are also infected who have no symptoms at all. And if you put those people in the bottom number, because they're not dying from COVID, that may reduce it substantially over time. So, but right now, it seems to be a fairly scary virus that overwhelms healthcare systems in a way that seasonal influenza does not.
Dr. Larson?
I would just add to that and say it's clearly deadly, no doubt about that. Because of all the analysis and information, we're going to figure out how deadly exactly, as Dr. Scrase has talked about. But it's clearly different than the seasonal flu. It affects older people more, younger people less, and it clearly, people with different sorts of comorbidities are at higher risk. I think one of the big challenges we're going to have to think about pretty quickly in just a few months, as you enter the next flu season, you're going to have 4 causes of flu. You'll have the usual influenza A, influenza B, what's called RSV or respiratory syncytial virus, which are the 3 that have always been around. And now you'll have COVID. And people will be presenting to their doctor or at home with very similar symptoms initially, sometimes not. And we're going to have to figure out a way to test for all of them and distinguish them and make sure people get the right therapy and the right treatment and the right isolation. And I think that's going to be part of the challenge in the fall. And we'll know more. We'll know how much herd immunity there is to COVID and whether there's a vaccine and so forth, just like we do for the flu. But it'll be a much more complex situation trying to distinguish all of those different cases potentially occurring at the same time and applying pressure on the health system.
It seems to me, not being a scientist, of course, but it seems to me that one way we know that COVID is more deadly or a more serious disease than the flu is we don't have a vaccine for COVID. We do for the flu, and one wonders if the flu vaccine were to just go away, would it tend to present more in terms of impact on healthcare system like COVID?
If I could just shift the commentary from something negative to something potentially positive. And that is one of the differences scientifically between COVID and the regular flu is that it's the molecule that we're trying to develop vaccines against is much larger, and there's areas on it that don't mutate. While on the regular flu, the areas mutate constantly. That's why you need a new vaccine every single year. So if one of these vaccines works for COVID, to one of these areas that does not mutate, then there's promise here for a vaccine that not only works on a higher percentage of the population than the regular flu vaccine does, but that it might last for more than 1 year. And so I think there's real promise, and the fact that there's 7 already being developed is important, because they're going to all have, some might work okay, and some might work great, and they might all have different durations of how long they work. And so it's really impressive what the U.S. pharmaceutical companies and governments have done in terms of getting this vaccine work, and universities, by the way, in getting this vaccine work so rapidly off the ground, and really does have promise. And promise doesn't mean certainty. It means there's real promise here that you really could not have even imagined a year ago. And I think that's something to really hang our hats on.
That's good. Julia Goldberg from Santa Fe Reporter is asking, does the state have in place a protocol for providing the vaccine to the public when and if it becomes available? What happens? So we have the vaccine, then what? What does the state government do then?
Yeah, well, that has not been developed yet, that protocol. And, other vaccines typically are delivered through normal channels, seeing your doctor or going to a big hospital system, getting them. But another slide you can't see is the mortality rate is very, very, very high in older people. You have to be above 80, and if you get COVID, your chances of dying from it are over 20%. And so as I've thought about how we would distribute the vaccine, it probably would be, you'd want to get to, and I'm not saying this selfishly, but healthcare workers are often near the front of the list, people most vulnerable to the disease due to their own physical conditioning or age, often are toward the front of the list. We don't really know what exactly is up with COVID in kids yet. There's some recent articles just the past couple of weeks that say, well, maybe they're not really transmitting it, but we don't know. And so I think it will be based on the protocol. Probably if we do have supplies that the state administers, would be on a risk-benefit-based priority system where the most vulnerable people and probably first responders and healthcare workers would be closer to the front of the line, I would think.
We are getting, you mentioned kids with COVID. There's a lot of questions about what have we seen nationally and in New Mexico about how it affects children. And lots of parents, myself included, definitely want to know what's the best thinking about summer camps for kids. But there are a lot of questions about what does COVID do when a child's infected. What have we seen here in New Mexico? Maybe we'll take that one first.
Yeah, well, I guess what we've seen in New Mexico is typically in other states, about 3% of total COVID cases are in children. In New Mexico, that number last week was 12.7%. So more than 4 times, not the percentage of kids that get COVID, but well, that's true too, but the percent of cases, kids are overrepresented. Kids tend not to have very serious illness. Often it goes undetected. There's things you can read in the medical literature that say they're super spreaders. And then you can read other articles that say they don't actually spread anything at all. And so I'm hoping that we'll know more. We use the Johns Hopkins model for risk, and it's behind all our reopening decisions. There are 3 criteria. Number 1 is how many people are there. So in a big summer camp, that's a lot of people. The more people, the riskier it is. Second criteria, what is the intensity of contact? So that goes with time and with proximity. So a lot more time and much closer to someone is, again, a bigger risk factor. And then lastly, the third factor is, can you modify those first 2 factors in a meaningful, guaranteed sort of way? So in some ways, summer camp is the prototype of the worst possible situation. Lots of kids close together, long period of time, hard to keep them apart. But if we had more information about how infectious kids were or how serious it was, I think we would have a much better answer to your question. There is a very, very serious, potentially lethal disease that kids, very small percent of kids are getting, maybe related to a rare disease called Kawasaki syndrome, multiple organ inflammatory disorder. And so far, only 200 to 300 kids in the world have had it. I don't know of a reported case in New Mexico. I checked with UNM last week. I don't know about this week. And so So it can be serious for a small percentage of kids.
Okay. Dr. Larson, did you have something to add, or should we?
No, I think that's a great summary.
Let's see. I'm not sure how we pronounce it. Shalene McQueen asks, is remdesivir available in New Mexico for COVID-19 treatment currently?
Yes.
Okay.
I think through the efforts of a lot of people at the state and federal level, our leaders, our political leaders, we were able to obtain remdesivir, and it is available in the state, and it is being used in mostly more severe cases of COVID.
Okay. And then she asked about a medicine I've not heard of.
Dave wanted, Dr. Scrase wanted.
Dr. Scrase.
Yeah, I can talk about that, and then one of us can talk about ivermectin. But we have received 3 different aliquots of remdesivir so far. I believe, I'm doing math in my head real quickly, which is dangerous, but about 400 vials on the 13th of May, and then it looks like another 700 vials around the 18th of May, and then we got another shipment that looks to be in the 700 vial neighborhood on around May 21st. So it is coming in regularly from the federal government. There's a paper out yesterday that shows that it actually speeds up recovery from an average of 14 days to about 10 days. So cuts 4 days off and reduces mortality rate. So it's a promising drug. It is being used, and any hospital can apply to the state to get a distribution of it. There's a lot of paperwork involved, just to warn you if you're a small hospital. But it's being, as Dr. Larson said, it's being used on sicker patients in the intensive care, and the federal government has reserved its use for people on ventilators or very, very ill in ICUs. And I'll start with ivermectin. There is a paper that shows if you have COVID and your COVID is in a Petri dish, then and you put ivermectin in your Petri dish, it will kill COVID. But we don't really know anything about what it does if you have COVID and it's inside your body. That we don't know yet.
I have nothing to add to that.
And, doctor, I can't let the opportunity go by. If you're making doctors fill out a lot of paper for remdesivir, what's the point? You can never read what you guys write anyway.
Yeah, that's true. It's a federal requirement, though, not a state requirement.
A lot of the paper is on computers now, so it helps.
Right.
That's right. I guess with technology, the poor handwriting and doctors' jokes are kind of anachronistic. Charles Goodmacher says, my 13-year-old daughter's volleyball team has practiced twice a week. They're following all healthcare and CDC guidelines, but don't wear masks. How safe is it to be in volleyball practice right now? And do you need to have a mask during your practice?
Well, going back to Johns Hopkins, it's how many people. That would be a very, very disciplined volleyball team if they all stay 6 feet from each other at all times, especially from what I know about how people set up spikes and all. I suppose it's possible. It's very difficult to wear masks if you're exercising vigorously like a volleyball team would do. And they didn't say how many people were on a team. I think it's typically 6, and that's over the mass gathering rule right now for the state. So
there is 2-person volleyball. So
that's true.
So the other thing I would say is in the category that Dr. Scrase mentioned of able to modify the environment, if this was done outdoors where there's more free airflow, or if it was done indoors with higher airflow, that would potentially help. It doesn't necessarily prevent, but it does help to have airflow and sunshine.
There's a few questions about face protectors, those like plastic sheets, and are those better? Are those equal to? Are those worse than wearing a cloth face covering?
I have a little something on that here somewhere. There was one study that showed that they actually so per what Dr. Larson said earlier, face protectors are more likely to keep you from getting COVID. And so healthcare workers use them with a mask when they're swabbing people to take specimens and the like. They mainly protect your eyes from water droplets that are coming from the respiratory system of someone potentially with COVID from getting into your eyes, or your because a mask won't cover your eyes. And so there was one brief study that suggested they were more effective, but let me see.
But they're basically designed to stop you from being infected by an infected person. The cloth mask, again, is protecting everybody from being infected by somebody who doesn't know they're infected.
Okay. What can you tell us about the type of antibody testing that is available currently in New Mexico? There's a lot that you see on the news about false positives and false negatives, depending on the type of antibody test. I know that in Santa Fe, it's being provided at Christus St. Vincent Hospital. I'm sure it's being provided elsewhere. What do you know, or can you tell us what type of testing is being provided and currently in state, and what's its reliability?
Can I? Yeah.
Yeah,
so,
go ahead.
yeah. So, if for whatever reason you consult with your physician and you think you need an antibody test, you need to have it done at a CLIA certified lab and have an FDA approved test. One of the challenges that happened in this area is there were tests that were produced mainly in other countries that weren't very good. They never became FDA approved. And so there are FDA approved tests right now. And if they're done at what's called a CLIA certified laboratory, like up at St. Christus, as you point out, then they're pretty good. So they'll tell you if you've been exposed. It won't tell you if you're immune.
Right.
And so that's the gist of it. But people are trying to work out. I think we lost Dr. Scrase.
I'm back.
People are trying to work out modifications of the test to determine if a person is immune or not. But that's a few months off from being able to do that.
I was just going to add that our lab experts in the state, working with the medical advisory team, prepared 3 papers on antibody.
Looks like he's
testing.
trying to get back on.
Oh, can you not hear me?
We can hear him. We can hear his voice is going out. We can hear him.
Dr. Scrase, would you like to add to that?
Yeah, I was just going to say on the medical advisory team website, there are 3 papers. One that sort of says what Dr. Larson was saying before I got cut off, that the tests that really are reliable are the ones that are run on bench machines in reference laboratories or in hospitals. The FDA has just recalled permission to develop testing for dozens and dozens of folks doing antibody testing. The point of service antibody tests aren't reliable, and further, they generally aren't reported back to the Department of Health, where we need to know the results of all those tests in order to monitor what's going on in the state and figure out where we may have a new outbreak. So, and then the CDC just released guidance about what to do with your antibody test results, which I can summarize really quickly. First, if your test is positive, that means you probably had a COVID infection, and you should talk to your provider about what that means. But if you're not having symptoms, don't do anything differently. And if your test is negative, it means you probably didn't have a COVID infection. You should talk to your provider about what that means, but you shouldn't do anything differently. And one thing that Dr. Larson and I learned in our first week of medical school that he knows best, because he's a pathologist, is if you're going to order a laboratory test and you're not going to do anything differently depending on the result, then you shouldn't order it in the first place. And unfortunately, that really is where we are for individuals with antibody tests right now. I think epidemiologists will be using them around the state, testing maybe 2,000 to 5,000 people to see if other folks have been infected and to what extent. But right now, it doesn't change behavior. It doesn't change anything you do.
Great. Yeah, the common denominator, don't do anything differently. It's very important to remember. Well, we always want to respect everyone's time, and we're almost to 4 o'clock. And as soon as we get to the end, Dr. Scrase, Dr. Larson, is there any final thought or comment that you'd like to share with the folks watching at home or watching this video, this recording later? Dr. Larson, why don't we start with you?
Well, I always like to end on something positive. The trend is our friend. Things are starting to open up and get better, and the disease incidence is coming down, and we just need to kind of stay the course and open up slowly, and things are getting better, and we can look forward to new therapies and hopefully new vaccines.
And I would just add to what Dr. Larson said that, we do have this exercise now where we have to live in a COVID positive world till we all have immunity, which is probably going to come from a vaccine and probably is at least 12 months out. So careful, slowly reopening things, experimenting, watching our data, see if we get new outbreaks is important. We can't continue the economy the way it's been for a year. I have a lot of decisions at home, like should our son drive from Michigan to visit us? And my wife's worried if he brings COVID. And I said, well, are you willing to go for 18 months without seeing him? She said, well, no. I said, well, if we're not willing to go 18 months, we might as well do it now. There's nothing really that different that's going to happen. We'll do social distancing initially and masks and things like that. But I think we all need to figure out how to live in this COVID positive world. And the way to get there is not to politicize any of the interventions. The COVID virus does not have politics. It doesn't respect boundaries, doesn't have a political party. We just need to do everything we can to fight it. And I think that there's some reasonably good evidence that wearing a mask to protect other people from you is not only a effective thing, but it's a caring, kind thing. And we're all going to have to be more kind and caring to each other for the next 18 months till we get to the post COVID positive world.
Yeah. Well, I really appreciate the hopefulness and the common sense thought. And it's really true. We all have them. We can all wear them. That's my homemade mask. And I'm just saying, it seems like there's a lot of folks out there who feel like they're too macho to wear a mask. And I we show people that you're strong enough to wear a mask, that it's not something to be embarrassed of. It's not something to be afraid of. And if doing this means that someone's loved one doesn't die from the disease, I'm willing to endure a little bit of inconvenience so that folks can stay happy and healthy in their homes with their loved ones. It's a small thing to ask. It's very effective. And Dr. Scrase, I've been following your guidance. I haven't left Santa Fe in a long time, but I can tell you that at the grocery stores, at the hardware stores, the nurseries, the rate of people complying with the guidance of face masks is very, very high. Last Saturday, I was in 4 different shops. I saved all my non-essentials for when it was, proper to go out. So I had a lot of errands, and I saw out of the whole day, probably saw hundreds of people. One was not wearing a mask, and I was very encouraged by that. I really hope that continues, and we not let our guard down. That as we do start to reopen, just know that each phase of the reopening, we're able to do it because we are adapting to what it means to be living in a COVID positive world. As you said, we got another big benchmark coming up on June 1st. And if people dine out responsibly and if people follow the guidance, then we'll continue to be able to have that phased reopening. And we'll all get through this together. Dr. Larson and Dr. Scrase, I want to thank you for your leadership through this crisis. It is incredibly reassuring to every New Mexican that you are part of the team that is helping guide the governor's decisions that keep us safe and have put us in a position of being one of only 2 states in the whole country that is ready to responsibly open. So thank you both for everything that you're doing to help our families, our health, our communities, and our economy get back on track. We will be back next Wednesday at 3. We'll have a topic announced, I think, Friday. So please stay tuned. Same place, same channel, right here next Wednesday at 3 o'clock. And in the meantime, everyone, stay home unless you need to leave. Stay safe. Enjoy your families. And God bless you all. We'll see you next week. Bye-bye.
Thank you very much.
Thanks.
Bye-bye.